and gentlemen, and a very warm welcome to day 2 of the NIHA Forum. My name is Priyanka Anand and I will be your MC again. After a very successful day yesterday, I'm sure you're all eager to begin today's session, so I'll just start explaining today's program. We have a plenary session titled Health Policy Challenges and Opportunities in Asia. This will be chaired by Professor Chiaki Singh, Head and Professor, Department of Epidemiology and Public Health. There will be 4 presentations during this session. Each presentation will be followed by a question and answer session. We will then break for tea, which will be followed by 4 breakout sessions with a similar format as we had yesterday. This will be followed by a plenary closing, after which we will proceed for lunch. I would now like to invite Professor Sitaram, Director of the NUS Global Asia Institute, to please give a summary of discussions that took place yesterday.
Very good morning to all of you again. The Western way of starting the day is to tell a joke, but the Eastern way is to give an apology. My first apology is for not giving you enough sleep because he kept you busy and awake until late in the evening yesterday. The another apology, if some of you may have had, I think there was a transport delay yesterday when you were leaving late night. The bus took some time to come. Apologies for that. The last apology is if some of you were not enjoying the meals or some of the arrangements that were not very well done yesterday, we will try to make up and improve on it today. So please do give us your feedback. So with that, let me summarize in just 3 slides as what we heard yesterday. Later, I'll request our colleagues, Professor Chiaki Singh and Dr. Jeremy Lim and Professor Showalter, to add in any of the points that were missed out in this summary. What we have learned from the breakout session, as you know, we had 4 breakout sessions. More or less, we all followed the similar format. However, we did not agree how to conduct the sessions. We wanted to be participatory, so each of the groups may have had discussions in different ways. The first message is that healthcare in Asia has great diversity and complexity. And this was, I think, brought about during the plenary discussions as well. The second message is that we need scientific evidence to support the healthcare policy, although it may be different from what is needed for academic research. I mean, this is where I think in the dialogue session with the minister, we also spoke about that the policy making is not necessarily just as straightforward and linear. In that context, evidence alone is not sufficient because it's the way you present and how you do is more important than what you wish to do and what you wish to achieve. So the process, and some of the countries do not have the enabling political or social environment to really get things done the way we may want to do it as a textbook approach. So in that context, the country's specific context and the political dimensions are crucial and important. And I think that brings us really together here, look at how Asia is so different from the rest of the world in terms of the complexities and the diversity. So the conclusion was that the policy issues on healthcare cuts across many domains, and we should be responsible to look at it in a way that it encompasses all the branches of the government. I myself believe that, for example, the ministries of water, environment, all these will have a role to play when we talk about health policy. So it's not just one ministry delivering health and health services. We try to, lots of thought leaders have shown me that when you make a 2x2 matrix, you're making progress. So we try to box all the thoughts and issues that came in a 2x2 matrix. So these are not, again, limiting or constraining, but try to clarify or select some of them. So not in any order, but the first one, obvious one, is the comparative health systems analysis and also health system regulatory analysis. I think these would be something of interest. We want to know what exists in Asia and what are the challenges that are there. Then we want to look at the assessment of the healthcare technology and also build capacity to really get better technology and assess them. And this is something it was discussed in the plenary discussions as well. Then we want to look at the data gathering. I mean, this is one of the issues that was hotly discussed, and we will talk about it later in the breakout sessions today, because without data, we won't be able to know or measure any of the outcomes, and if we don't measure, we won't be able to really achieve any of the targets. Then finally, the discussion that came about, starting from the minister's dialogue, is the behavioral changes and how consumers, patients, and suppliers behave, and what are the kind of incentives which make them do what they do. And we may want to study about this, and this is prevalent in other areas of consumer goods and so on. Now, what does it mean for healthcare technology and healthcare services? I know that this was quite controversial and exciting discussion. The matrix was attempted. Some of you may agree or may not agree, but the polling results show that we now have some sort of convergence on possible topics. So out of the 15, we were able to zero in on 8, which scored more than 20 out of the scores that was given. But we may need to discuss more today in the discussions whether these are the ones that we agree, or there were some, at least in the group that I was participating, that they said that there should be one more row or one more column, or some of the things that they were prioritizing were not possible to be mapped onto this matrix at all. So I think this discussion we will continue to have. So that's the 3 slides. If there are any quick reactions or comments from the other facilitators, I'll leave the floor open and then hand it back to Professor Chair Casing. Yeah.
I might just pick up on one thing you mentioned, which I think is very important, although we didn't discuss it specifically in the Green group, and that is the fact that one has to be careful to differentiate between the research that's applicable to policy and the research that's applicable to science. They aren't orthogonal, but they certainly aren't totally aligned either, and one has to be careful, I think, that you don't get these two mixed up, or both of these qualities will lose in that effort. So I think it's a very good point to have made.
I had one comment and one question. The comment is that, many of us have been in the civil service before, and the general dictum is that we should base the thoughts and ideas and the concepts on the best evidence and science, and then the politicians can layer onto it how they want to approach it, taking into account the political contexts of a place. And so I am sure so just to perhaps make a point that the work that we do would be science driven.
Correct.
But when in its application, of course, those who are going to have to apply it will then have to overlay it with the political considerations. The question I have is, how do you actually interpret this chart? What do the numbers mean and so on? Thank you.
Keesing, would you want to jump in? Because I'm just reading the slide.
I think we mustn't read too much firstly into this. Essentially, I think the framework actually highlights the importance of the relationship between many intersections. So, for example, if someone come up with a particular issue, it will cover several intersections. In fact, many of you actually, when you mention item 1, for example, you said it covers all 18 intersections. Yeah. And I think that's the message that essentially we want to get across. It's not so much the for use for prioritization. Right? It's just to mainly show the linkages. But in spite of that, we do see certain rough pattern emerging from that.
Yeah.
I don't know whether we were the only group that discussed this, but one point that doesn't show up here is the extent to which the policy issues affecting the way healthcare is delivered, the way it's financed, and the manpower issues is shaped by forces in the larger political environment. And I think that's a very important, it was at least for us, a quite important point, that you don't want to be restricting your view to things internal to the healthcare arrangements when you're thinking about what the capacity is to do anything in this sector at all. And it goes in part to what the President was saying too. Of course you want to have the best social science, natural science work, but the object of analysis is also the way institutions operate. And that was a big theme in our discussion And I don't see that here. That's fine. We were thinking in terms of an overlay on these perfectly useful elements of a matrix, but that overlay is quite important.
Okay, thank you. There are two, Jeremy and then EK.
Please. Okay, good.
I think along the lines of what Ted was saying, and maybe I'll clarify some of those concepts when I cover the talk later, because also what the President has been saying about the role of scientific evidence. I think when we study policy, there can be three objectives. You can look at it as a study to policy, which means that we do our things, we give it to policy. We just leave everything in the context of the policy environment. Then you can look at it in terms of study for policy, which means that we provide the types of evidence to what you're discussing in terms of the types of evidence required for policy adoption and implementation. So we're more active. We recognize that we have a role in terms of the building of evidence to enable policy to happen. So that's very important perspective. The third is in terms of study research of policy, which means that it's retrospective, usually, and that we are just studying the policy process so that we can then use it as a mechanism to influence policy in some way. So we can look at it in those three perspectives and see what the role of NIHA is, how we see our roles in policy, whether we just want to be very passive, studying to policy, or studying for policy, so we're more active in terms of, because if we want to have an impact on health in Asia, that part which is missing. So we're just saying that that's not our role, but someone's still got to do it. So if we consciously say we're not going to engage in it, we must recognize that we must advocate for it and someone else must do it. Or then we can look at in terms of studies of policy, in which means it's something that we understand. Maybe initially we want to look at of policy so that we can understand the policy process, and then we can then feed back into our systems and adjust it as we go along. So I think conceptually we can look in those three ways, and it'd be quite important for us to recognize that, and then we can review it as we go along. I mean, we might in the first year say that we just ignore it, it's just too policy because it's too complex. Or we can say that we want to, next stage would be off policy, so we can then be more active in engagement. And the third part could be as a stage, we then study for policy. So we could look at it even in stages. It doesn't need to be a one-off, once and for all. But if you understand those approaches, then perhaps then we can then have a debate later on. Are those the approaches appropriate for us? Which approach do we want to take today? And then do we want to move forward? And it can be an evolutionary process as we go along. We can look at it as we proceed. Because these issues, as I said, are too complex. And we need to start somewhere, which I totally agree. Because you cannot handle the whole universe in one go, because you talk about political sciences, you talk about policy sciences, and the universe is so big. So what is it? What are our strengths of this group? How do we actually start? Okay.
Excellent.
Well, the three of us were all from the red group that had a lot of things to say about the framework, so apologies in really advance. But the comment is, it is well taken that the framework in its current state really doesn't emphasize strongly enough the social context or the really political milieu of how countries operate. The way that I had looked at it was in the form of three I's. The first I would be the infrastructure. What is the information and what are the institutions? And that is somewhat empirical. It's really to give a sense of what is out there and what is the state of readiness. The second I comes from TED, which is around the ideas, which may be an ideal platform, which may be best taken up by a structure such as this policy forum, where ideas can essentially be rigorously discussed and they can be percolated up. And the last revolves around the implementation, which brings us back to the President's point: how are decisions actually made, and how are decisions implemented? And the way that I was looking at this, I felt that the infrastructure fits very nicely into the research agenda for NIHA. The ideas sits nicely with for example, with the Well Policy Forum, and the implementation should probably be a strong thrust of the upcoming leadership program.
Excellent. Thank you very much. Okay, thank you very much. Kiseng, you want to add?
Thank you, Professor Sitaram. I would now like to invite Professor Chiaki Singh to please chair the plenary session and to please open it as well.
Okay, so this morning we'll have 4 more sessions, 4 more lectures covering the opportunities for healthcare policy research in Asia. And then subsequently I'll give a short briefing for the breakout session, and then you'll go for your breakout session following the tea break. Priyanka will introduce the first speaker.
The first presentation will be by Professor Mark Zimmerman, Professor and Chair, Health Behavior and Health Education, Center for Human Growth and Development, Michigan School of Public Health, US. He will speak on behavior change for health promotion and disease prevention.
First of all, I want to say thank you for inviting me here today. It's special. It's actually, except for crossing the Bosphorus in Europe, in Turkey, this is my first visit to Asia, so I'm pleased to be here. And again, thank you very much. I hope what I have to say might be of interest. It's going to be completely different of everything that we've talked about so far, mainly because I'm a behavioral scientist, and I might be the only behavioral scientist in the room. I'm not sure that's absolutely true, but most of the people I met yesterday were not behavioral scientists, so you'll hear something pretty different. First, I want to, the 3 things I'd really like to communicate today is 1, this ecological perspective, then 2, the importance of theory, 3, the importance of implementation, which we just heard about a little bit right now. And I actually think the ecological perspective cuts across culture and setting and has relevance no matter where you work. And I've worked in other parts of the world, but again, not Asia. The other thing, just about theories, I'm going to be talking about some theories that come from the United States that have been somewhat tested in other settings, but mostly the United States. I realize that they may not be relevant here, but still I think there's a larger point that I'm going to be trying to make. So first let me talk about the ecological perspective. And this perspective suggests that the individual is one piece of the larger pie, and that the individual is influenced by other factors. The individual is also influenced by family and peers and friends, and that the individual may engage in behaviors that are a part of the family structure, that are part of what happens in the family, part of the family traditions, and the family traditions may have an effect on the individual, and the individual may also have an effect on family and friends. I made too many hits to have to get through all these. And that the individual is also, and the family and the friends are also influenced by a larger context of the community and the neighborhoods. The neighborhood might be the people who live in the same building or in the same couple of buildings, and a community might be a set of buildings or a set of blocks in the United States and that sort of thing. So the community also has sort of a different context. In the United States, for example, there are some communities that are more violent than others, and violence may have an effect on how people might be engaging in different kinds of behaviors or what kinds of choices they might be able to make because they don't feel safe in their community. And then the level that everybody's been talking about, which is policy and culture. And by culture, I mean everything from the norms of a society to the culture, the political culture, and how things get changed or influenced in that context. So secondly, I'd like to just mention, so with that backdrop, the idea of theory is very important, because theory kind of directs us to the kinds of questions that we'll ask, the kinds of variables that we might measure, the kinds of places where we might make change. And so theory is an important part of behavioral science because it kind of guides, it gives us a framework for guiding what we're going to do, how we're going to research, how we're going to change behavior, and ultimately how we might implement policies that would be relevant to help people engage in healthier behaviors. I also wanted to say, before I go on too much further here, and that is, because we're focusing on individuals doesn't mean that the individual, and that this is the part of the point of the ecological model, that the individual is not necessarily responsible for their own behaviors all the time. So that there are contextual factors that may influence how an individual behaves. However, The ecological model is not intended to suggest that people don't have responsibilities for their own behavior, and the idea is that it's an interaction of the two. So just on the thinking about, oh, that's great. Is it the red button on the top? That's this one,
Yeah.
right? It's the arrow that points to the right. Just really quickly, the idea of some behavioral theories, and what I'm going to do is talk about theories at all the different kinds of levels that I just mentioned in the ecological model. The health belief model, the theory of planned behavior, these four models are pretty classic health behavior theories. They suggest that people's attitudes, their perceptions of susceptibility to a disease, their severity to the disease in the health belief model, their belief that they could actually engage in the behavior that will help them be healthier, like in the social cognitive theory called self-efficacy. There's actually some evidence that self-efficacy cuts across cultures and is something that is relevant in many different settings. The stages of change model is the idea that a person is only going to change their behavior if they're ready to make that change. That kind of grew out of the whole literature on smoking behavior, that you can't get somebody to quit smoking unless they're ready to quit smoking. So stages of change, pre-contemplation, where you're not even thinking about changing, then you're at a contemplation stage, you're thinking about changing, and then you're at the ready stage, and then you know that person is very much ready to kind of maybe make some kind of behavioral change. Then there's interpersonal theories, and interpersonal theories are social support, and these kind of cut across the community, neighborhood, and the family and friends. Role modeling and mentors, the role that other people have in either encouraging us to do a particular behavior or discouraging us from doing a particular behavior. A good example of the role modeling is with children. Children will also, especially adolescents, will often engage in the behaviors of their friends. And so if you understand how those two factors might be related, an intervention for helping improve somebody's, an adolescent's behavior so that they don't get involved in early sexual behaviors or risky sexual behaviors might be to help them avoid susceptibility to the peer pressures that they might be exposed to. Family systems is the culture and the norms and the morals and everything that gets communicated in a family. A family of 7 children versus a family of 2 children creates quite a different dynamic, and that's kind of where the family systems theory is. And social support is the idea that we are not usually living in isolation, that we do interact with other people. On the community theories, diffusion of innovation, we talked a little bit about this yesterday, it was brought up, this idea about how do ideas get spread, and there's a whole series of theories and research on this. Everett Rogers kind of was one of, I guess you could argue, the father of the diffusion of innovation theory, and he talks about the compatibility of the messages or of the behavior, the advantages to the person who's trying to engage the behavior, and basically the idea is how do you move forward in changing a behavior, and getting people to engage a particular behavior. So, so theories can cut across different areas, and they all guide us in what we might be paying attention to, and obviously it's more complex than I'm able to go through. The next series of issues is how do you implement these things, these ideas, and how do you create a program that you could even think about it at the community level, at the individual level, or at the policy level. And I'm going to talk a little bit about these. Some of you, I think, may have heard about motivational interviewing. This is individual focus. It's almost counseling. It's helping people get a sense of, get them to be motivated to make changes. It's help them to explore their ambivalence to changing a behavior like smoking cigarettes, a behavior like not engaging in physical activity, a behavior like following the medical regimen that a physician gives to you. It's very goal-directed and, again, very individual level, and it may be focused on helping people see their susceptibility to peer pressure. It may help them gain confidence and self-efficacy to be able to engage in the behavior. Another area of implementation is social networks, doing an analysis. If you're thinking about families and you're thinking about the role that friends and social support may play, would be looking at social networks, where you look at network characteristics such as density, how many friends does somebody have, what are the linkages between those friends, is there one person who is a key member of of a network that most people go to for advice. That might be somebody you'd want to intervene with or provide support to, since they're often stressed by everybody going to them. The network processes, what kind of information gets, network processing and content. The content is what gets communicated, and the processes is how does it get communicated. With the advent of the internet, the process is often now with Facebook. I'm sure you've all heard of Facebook. Lots of advice, lots of challenges are happening now virtually. But the idea is, what is the kind of information that gets communicated, and how does that get communicated? And that would also direct how you might do an intervention or create a program. Lastly is participation and empowerment is another process. The idea of empowerment is basically that you engage the folks that you are trying to work with. So that some of the work that I'm doing in the United States, we the academics sit around the table with community-based organizations, non-governmental organizations. We actually also have some governmental organizations, and we work together to try to solve the problem. It helps us make our work more locally relevant. It helps us kind of think more ecologically about the context in which we're operating, and then it focuses on the community changes that might need to take place in order for somebody to engage in the healthy behaviors. So what I'd like to do, and I'm not keeping track of my time, I hope I'm not talking too fast. What I'd like to do is I have 3 examples of behavior change related activities, looking at the individual, interpersonal, and a community policy level. First is smoking cessation. We here at the University of Michigan, where I work, there is a no smoking policy in any of the buildings. So people have to step outside and they have to be about 20 feet away from the door to be able to smoke cigarettes. And where I live, it gets pretty cold in the winter to -0 centigrade. So it gets pretty chilly to be out there smoking cigarettes. And actually, starting July 1 of 2011, you will not be able to smoke a cigarette on the campus of the University of Michigan, anywhere on the campus. You will not be allowed to smoke a cigarette. What exactly happens if you do, I'm not sure. But the policy is that you won't be able to smoke. But what the university is recognizing is that people need to learn how to may need to learn how to quit. And so what the university is doing is providing smoking cessation programs for free after that date for anybody who wants to try to quit smoking. So the idea of cessation is obviously people who are already smoking. It's an individual level focus, and you try to give them supports. Peer influences, some of the most effective smoking cessation programs in the United States have been found to actually engage people's social networks. So you help people quit smoking, but then you engage their family members to help them say, don't smoke now. I know you always like to smoke after you eat dinner. Let's not smoke now. Let's go for a walk instead. And so engaging the family in those processes. And then I gave you an example of a no smoking policy. The city in which I live in, Ann Arbor, just recently, actually the state of Michigan just recently passed a no smoking in restaurants policy. So you don't have to go into a restaurant and ask for no smoking anymore. But those policies, again, have an influence on how people then behave and thinking about cessation. And smoking, I know, is an issue for just about every society in the world. Even in the United States, where we're starting to implement a lot of these policies, 1 in 4 to 5 children still smoke cigarettes, in spite of the fact that they can't buy them legally, and in spite of the fact that there's all of these campaigns to get them to not start smoking. 1 in 4 to 5 people. So clearly these are still issues. Another example of physical activity, and we know that smoking, by the way, is probably one of the most important health behaviors that is health damaging. And so that's an important focus. Physical activity is another one that's related to all sorts of outcomes like diabetes and heart disease and obesity and those sorts of things. And so an examples here at the individual level, there might be personal training or a coach. We have lots of programs like that in the United States where there's coaches to help people change their behaviors. So they are completing a health risk appraisal, and then a coach helps them kind of do the kinds of activities they need to do to overcome or to engage in the healthy behavior. Exercise groups in the School of Public Health, we have a noon exercise groups where people go and walk together. Sometimes if it's too cold, they just walk around the building and there's lots of stairs, and so they walk up and down stairs. Or they go for a walk for about 45 minutes. So they're creating the idea of social support and having support to engage in these behaviors. And then the idea of safe spaces for activity. a city can engage in developing a park that and make sure that park is a safe place to exercise, make sure that the paths to walk in are well kept and are soft on the knees. Lastly, chronic disease management, some examples from that. There's the self-regulation. There's a whole research on helping people manage their own disease by monitoring their blood levels or getting the kind of self-efficacy, basically, that they need to be able to feel like they can manage their own disease. Family supports. There's lots of evidence and lots of activities where families are helping the individual engage in healthier behaviors. For example, they might work in the family to change some of the traditions of food cooking. So instead of deep frying food or eating high-fat foods, they might change the way they might eat, and that would be help a person manage perhaps their diabetes. And then the physician training would be another example of a community that's outside the individuals, but there's been programs where physicians are trained to do screening and to ask certain questions of people to help them maintain their control of their diabetes or their control of whatever disease that they're trying to manage. So I think I'll end there, and I hope I didn't go overtime or I would leave enough time for questions. And again, I realize that some of these may be very individual, may be somewhat culturally bound, but the idea of thinking ecologically and how the different levels interact with one another to create behavior change, either to engage in healthier behaviors or to avoid the negative behaviors. Thank you for your time and your attention. I appreciate it.
Thanks, Mark. I think we have time for a couple of questions.
Is there any moment in time that you would declare victory? I mean, you're talking, what I found interesting, that in the thinking about how we have to change our own or our neighbors' behaviors, it's almost framed in moralistic terms or paternalistic terms rather. I mean, you're talking about negative behaviors. Couldn't you say, well, given the fact if you look what dramatic advances we've made in the last century in, for example, the reduction of child mortality or maternity, and our life expectancy has gone up dramatically. At what time do we say enough is enough? So if a couple of guys want to continue smoking, so what? I mean, it's as if the framing, and I'm not sure that's what you meant, but it's as if the framing is we all of us should be healthy, and you better stop smoking, and you better stop drinking, and stop eating that junk food. I mean, I'm a bit trivializing, but I'm a bit sort of puzzled about the notion that there is almost a moral need to improve our health. There's no limit to that, or is there?
Well, it's a fair enough question. I mean, we're also, I think in some ways, I think we're all here. When we look at what are the risk factors for negative behaviors, for example, let's say obesity in the United States, it's obviously it's a huge problem, no pun intended. We also know that, for example, smoking. We know that these things are risk factors for increasing the cost of medical care, increasing the costs and both financial costs and the social costs. So we can decide not to do anything, but when we're implementing a policy, whether we're that we want people to change their we're hoping that people won't do those kinds of behaviors, we are making that same kind of choice, whether we're doing it at the individual level or not. I mean, it's certainly true that we can decide not to do anything and just put things in, put policies in place and hope for the best. But in the United States, we're trying to think about ways to control costs. And it's not necessarily being paternalistic, it's kind of creating the context and the strategies for helping people engage in health behaviors if they choose to do so. Nobody's being paternalistic in that we're saying if you don't do this, you're going to go to jail or something like that. So it's not moralizing, it's trying to create the context for people to engage in the kinds of behaviors that they might themselves choose to engage in. And what we do is, in terms of the question about, well, how do you know you've achieved it? Well, this is what research is all about. I mean, we do randomized controlled trials, just like we do with drugs. We don't force people to take a diabetic medication, but we know if they take this medication, it's a useful strategy. So then we need to think about, okay, so if we know they take this medication, it'll help control their diabetes, how do we get them to pay attention to the doctor's suggestion that they should do this? So then we create a program where we test out, using some theory, whether or not if we show whether we can increase their engagement in the adherence to the medical regimen, what are the things that we have to do to get people to engage in that medical regimen? Now, you could call it moralizing. When the physician gives you the prescription, they fill out the prescription or not, and you decide whether, and they decide whether they're going to take it. I think many physicians would hope that they would actually take the medication and control their diabetes, as an example. So we need to kind of figure out some strategies where how then can we have them follow that regimen? Whether they do or not is, of course, up to them. I mean, you know, we're not necessarily being moralistic. What we're doing is we're trying to understand how we can increase the chances that somebody would do the kinds of behaviors that we know are related to better health outcomes. And so in terms of, you know, how do you know you've made it? I mean, this is what statistics are, and you have, you know, you test them out in a randomized controlled trial, and you see if by taking this they do a little bit, you know, the people in one program are more likely to engage in the regimen than people in not the program.
Jeremy, you have something to add?
Well, thanks, Mark. If we applied a more ecological framework to, say, countries that are relatively healthier, like, say, Japan, or even countries that have transformed their health-seeking behavior, like, for example, Finland and the story with diet and so on, what really would be your comments about the critical success factors for these healthier societies?
That's a tough question. Actually, I mean, I come from the perspective that we really need to work on all the different levels, that a policy alone doesn't necessarily work, and that individual behavior change doesn't necessarily work. But that we need to create the context, both within the families and the communities and the policies that would help support an individual to either engage in the health behavior or increase the chances that they could. In the United States, when somebody is in a very violent neighborhood, that you can tell them all you want that it'd be a good idea to get exercise after dinner, walk so that your blood sugars won't be so bad, and they're going to say, no, I'm not going to go out there, I might get hurt. So I think you need to think about all those levels, and you know, it's hard to say, like, you know, in one country why does it work versus another. I think the more homogeneity within a society, probably the easier it is to make you know, widespread change. The more heterogeneity in terms of ethnicities and racial backgrounds, I think that makes it a lot more complex, a lot more difficult. Did I answer your question?
I'd like to follow up on Dr. Lim's question. Particularly looking at the community and from the population's perspective. Your presentation has focused principally on the behavioral modification for individuals, and I can understand that, but is there a difference if you want to move the whole of the community with you in terms of certain behavioral modification? In other words, is community development or community participation approach different from what you have just presented? Could you perhaps highlight some of the key differences?
The key differences between a community development and individual behavior change. I spoke about behavior change because that's what I was asked to talk about, by the way. I do research in behavior change. We actually do both at the same time. We're trying to engage our community partners, for example, in thinking about strategies that we can help think about ways to reduce what we see in disparities, for example, between African American or low income populations and higher income populations. Why are people who are at the lower income, why do we see this socioeconomic gradient of lower income people not as healthy, as not engaging in as healthy behaviors, or don't have as healthy outcomes as others? And so we try to do is engage the community, do community development as a way to see what structures we could change in a particular context. And some of those structures might be focusing on individual behaviors, like cooking differently. So it's really a mix of the two, and doing them simultaneously. You know, in the United States, if we were to implement a policy, it isn't always true. I mean, we've implemented many policies, for example, for kids not to smoke cigarettes. We know that if they start smoking cigarettes at a young age, that they're likely to smoke cigarettes later. We know that they're going to smoke cigarettes, and it'll probably end up being a serious cause for absenteeism as well as illness, and cost the healthcare system a lot of money. But still, 1 in 4 children, 1 in 4 to 5 children smoke cigarettes. So there was a foundation in the United States that put together an effort that got kids involved in creating an ad campaign, an advertisement, health communications campaign, to help kids realize that smoking is not necessarily good for them, it's not cool, and they kind of fed into some of those activities. And so they were doing it at a media and community development level, engaging the kids, focusing on that particular behavior. Did that answer your question? Sort of.
Thanks, Mark. I think we need to move on. What I suggest is that to have a better flow in terms of the lectures, I suggest to have E.K. Yeo coming forward first to talk about the art and science of healthcare policy decisions.
Our next speaker for the day is Professor E.K. Yeo, Professor of Public Health, School of Public Health and Primary Care, Director, Center for Systems for Health, Hong Kong Chinese University. His topic is the art and science of making healthcare policy decisions. I'd like to invite Professor Yeo to please make his presentation.
Chairman, President, ladies and gentlemen, it's a great pleasure to be here and a great privilege to be part of this very challenging and visionary initiative of NUS. I was asked to talk about the arts and science of making healthcare policy decisions. In fact, there's not just the art, but there's also science to the art, except that the science doesn't reside in biomedical sciences. So I think we need to recognize that. What I intend to do in the next 20 minutes is to stimulate discussion of how we view policy in the context of the primary objectives and strategic directions of NIHA. I think that's quite important, and that's what I intend to do. And as I said, conceptually, we can view policy in NIHA as in two ways. One is as a primary objective in itself, so in which case, when you look at the framework, there's an overlay, and how you overlay it is, you can do it very differently. It can be in terms of multiple components, then you have multiple permutations of the boxes, which will make it so complex it will be impossible to function. And obviously, in terms of focus, that's not the way that can work. But an overlay could be in the context of looking at those things and then look at some of the things that you need to link up to it. So you could do it in that context, but it can be looked at as a primary goal of research. It can be also looked at as a tool for our frameworks, whatever framework we agree, that we recognize that it's a tool to effect some of the results we want to see. Because what we want to see is improvements in health. So if we just ignore that, or we don't understand it, nothing will happen, because we'll just present that, and I hope that in my presentation, I can convince you that you need to at least view it, and it must feature in our thinking. It must feature in terms of at least in an understanding of ourselves, of that part of the equation, and whether we consciously don't do anything about it at this moment in time, it must feature, and we must come and revisit it at some point in time. Okay? That's what I intend to do. So I'll start by going through an outline of my talk. I apologize to my very distinguished colleagues here who are in public policy, because my presentation is going to be very simplistic, because I will just pick up some of the features of some of these things in public policy which are relevant to our discussion. I think because of the very diverse backgrounds of this group, there are certain features of it which are important for our understanding in terms of discussion. So what I intend to do is to talk about a bit about the nature of public policy and convince you the importance, because if you're talking about improving health, public policy is the most effective vehicle to do it. So we are just the feeder systems.
The policy cycle is important because if you want to have a more active role, you want to understand the whole process. We don't want to be frustrated in our efforts in the future. We need to understand some of the elements of the policy cycle and the decision-making process in policy. I think that's quite key. How do policymakers decide? Because we had some insights from the minister yesterday, but can we have it a more better understanding that it's not a chaotic and a chance decision, that there is some science behind it, there's some knowledge behind how decisions are made, whatever model of decision making you talk about. And then we could then look at one or two approaches in studying policy, just examples so that we can see in terms of the possible roles that we have in studying policy. So I'm not going to cover the whole universe because it's not possible, and I'm not really that much of an academic in this area. My experience has been in public policy in terms of the implementer, and now studying public policy in terms of the academic and conceptual thinking. First, why is public policy important? Because it's the authoritative decisions. We have a lot of definitions. None of them are complete. None of them are satisfactory. But the ones that I've chosen, highlight certain features which are relevant to our discussion. First, this is the one that is authoritative decisions by government. So there are three branches of government, and you must always remember there are three branches: legislative, executive, and judicial. And judicial branches are very powerful, especially in federal governments like in the states, in republic states like in Philippines, in Indonesia, where states have laws. And the interpretation of laws are quite important, because laws can be found unconstitutional. They're against the basic constitution, or there are controversies between state laws and federal laws. So they're very powerful in interpreting policies. So I think these are the parts of government. And the other part of the definition which is important for us is that it influences the actions, behaviors, or decisions of others. So it's very, very powerful. And it's the most powerful tool that you could possibly have to improve health. And then you talk about health policy, which is by Bills and Mason Ward. It covers the actions and all inaction. Policy is not just about action, it's about inaction as well. Governments very often decide not to do anything, and that can be a policy. And that can be very frustrating for people in academia, in research, because of the inaction of government. And that can be a policy. So I think I want to put this definition because it's the action or inaction. And the other point which is important is both public and private. So when you talk about policy, health policy can be public or private. And the public policy, if in the absence of good public policies, in this vacuum, private policies can be very powerful. So like in America, where there is a lot of inaction before the Obama reforms, they talk about reform without reform. Because in the absence, in that vacuum, the private sector had its own reforms, its own policies in terms of HMOs, managed care organizations, payment systems, etc. So we must not forget that the private sector can be very powerful in the policy process in the absence of effective government policies. So in our approach to work, when we look at the diversity in our region, where the capacity in policy is very different, we might even want to target private policy in terms of doing some of the experiments and some of the models that we're talking about, and that can then also influence public policy. The nature of public policy, it's political, so by the very definition it's political because it's done by the three branches of government. It's got authority, it's complex, and it's dynamic. I think it's important because we need the complexity of this is something that, of course, in biomedical sciences we understand. We try to reduce it so they can be manageable. But it's many things in life are not simple. And then it's also important it's dynamic. It's not a linear process. It continues, it grows. It's growing like a growing organism. You have inputs and outputs. It grows, it shrinks, it atrophies, it hypertrophies, depending on the influences right through the different stages of policy. So it's not just one stage of policy that you look at in terms of influencing, it's all the stages of policy. So I think that's something that we need to understand of the nature of policy. Of course, the factors influence policy, I'll talk a bit about this: economic, social conditions, prevailing political values, structure of government, institutions, national and local norms, and international organizations. I'll talk about in this context. This is on the study of health policy, a framework. I think frameworks are not perfect, but they're useful for discussions. At least we talk about along the same wavelength that they had the frameworks for discussion. Never of these are perfect. But of course, in academia, we try to force things into a certain type of thinking, but it's helpful for our discussions. Because you look at this, the most important to me is the context. Because there are three components of it. The context, which is what we're discussing today. All the different countries, they're very, very different. What are the contexts? How are they different in context? So when you have the context, when you have a structure for that, then you can at least start to understand and using the context to explain differences, to study differences, and to see what works and doesn't work. Then you have really within the whole thing with the actors, people that affect policy and influence it, and then the whole process, which is a whole science in itself, and then finally the content in terms of what they actually do. And is it the content, because all these will affect the content of the policy, because what we feed in is not what will come out. In contextual, I think there are a few things. I just want to highlight three things. Situational, depends on the particular situation of that. Obviously, if there's a crisis, then governments are more likely to act. If there's a problem in terms of the situation of, say, currently the high property prices in Asia, you can see governments are intervening. Even governments that are market oriented, or the philosophy is market is king and governments are small. In Hong Kong, we have now moved because property prices has just gone up the roof. So in that situation, because of the political situation, the unrest of the community, government is forced to act. So the situation is quite important. International exogenous, it's very, very powerful. The WHO, the ADB, the World Bank Institutes have great influence. So when you say that what are the issues in the country, the issues may not be tuberculosis or malaria according to the politicians, but because WHO says it's a priority, and because they have got the authority, it forces changes. So international influence are very powerful. And when you look at what's happening in rentals, in the control of property prices, Singapore has measures, Korea has measures, Hong Kong has measures, and these are the bastions of capitalism and of markets in this region. And why have they acted? Because there are international influences. It influences the thinking. So you act upon the strength of one another. Like when we had the subprime crisis, everyone was bailing out the banks, started with Britain, then America, then everyone else. So everyone in the world changed. So the international influence are very powerful in terms of the things that you do. So we can learn from that in terms of then our strategy, catalyzing, moving forward our agenda. And then structural. Structural, I just want to mention one, which is important in this region. When you look at the structure of government, it determines in terms of what you can and cannot do, and it determines also the number of actors that can influence policies. So in this structure, which from book by Nagel, they divide it into the structure of governments into 5 parts. It talks about the relationships of national government to the state. As I said, in countries where you have federal governments or confederate governments, the power distribution is very different. So then there is a much greater distribution of power. So in these sort of structures, it talks about the distribution of power and the ability of one single body to influence the whole thing. So in America, where they have federal and state governments, where they have 2 houses, when you look at the discussions on reforms, there's a whole plethora of people. There's a whole profession of lobbyists in Washington because of the ability to influence the various decision makers. So the decisions doesn't write in one organization. But in the relationship between the chief executive to the legislature, as you say in presidential systems, you then have the other element of separation of powers between legislative and the executive. And the third is the courts, the executive, legislative branches. So courts are very powerful, as I said, and it depends on what roles the courts are given. Some courts are given roles to determine the constitutional aspects of the government, or to look at the relationships between the local and provincial governments, to look at whether laws are contrary to the higher laws like civil rights and civil liberties. So those are the roles of courts, and they're quite powerful. the Hong Kong government has been taken to the courts to challenge the legality of some of their actions. Like one particular instance was in the old days we had two streams going from primary school to secondary school. The boys had a separate stream and the girls had a separate stream, and the reason being that boys develop slower. So someone in the community took the government to court and challenged this view, and the courts ruled that this was discriminatory, and there was no insufficient evidence for that policy. So government had to change the policy. So quite powerful, the courts. Political parties to each other, because you talk about one political party, like in Singapore you have one dominant party, so it's more cohesive, the policy continues. In coalition governments, there's usually a more horse trading, a lot of compromises, and the government's the people, which means that whether it's an authoritative government or more democracy, in more democratic governments, there's greater participation. So these structural elements of government determine the actors and the powers and ability of different actors. Actors will include academics, like ourselves, and interest groups to influence policy. So it'll be quite important in terms of when we look at the effector arm, the different governments and the different backgrounds for our region in Asia will be very different. So the capacity to change things with our scientific evidence will be very different, just looking at the structure. The actors in this process, I said there are all these actors which are important that we need to remember. And you can separate them into classifications because their roles and the objectives are going to be different. You have the state actors, international we talked about. State actors would be the elected and the appointed. The elected would be the civil service, the people that actually do the groundwork. The appointed are going to be the elected will be the political arm. The appointed are the civil service arms, and the perspectives are going to be very different. And they have a different role in the whole process. And depending on the structure of the government, the influence will be very different. Societal would be the so-called political economic. In some countries, labor force is very powerful. In some communities, business sectors are very powerful. In Hong Kong, business sectors are very, very powerful. They have resources to influence policy, influence the thinking. Sometimes it's very subtle. Sometimes it's more formal in think tanks. They have money to fund think tanks that will influence policies, influence public thinking. Political, you have all these other areas. In political, you include the media and interest groups. Of course, all these actors are potentially there, and the influence on policy will depend on the whole context of that particular country. Now I want to go on to this process because we now move on to something slightly different in terms of how all this happens, because we talked about the context, the actors, the process. So this is the third component of the whole thing. And this is one way of looking at it. You have these stages of policy making, which is something the academics dream up, but obviously something that should happen, but it doesn't happen necessarily in that sequence, and not necessarily in a linear order. You have problem identification, issue recognition, policy formulation, implementation, evaluation. But it's useful for us because when we look at the whole policy process, if we want to do some work along these lines, we can tackle it in totality or at different sites of this process. 5-stage policy cycle, another way of looking at it, agenda setting, policy formulation, decision making, policy implementation, evaluation. Here is two things I want to highlight. Agenda setting is a very important area of policy because the policymakers on a daily basis are just submerged in a million issues. And how does it get on the agenda? I mean, you find that very often it takes a long time before they even put anything on the agenda. Although there's the science, nothing happens. So what is it that determines that? And there are lots of studies and models for looking at agenda setting, etc. I won't go into it, but it's a very important component of that. Because unless it gets onto the agenda, nothing will happen. Okay? And you need to understand some of the agenda setting process, some formal, some informal, some of the softer parts and some of the scientific parts. Policy formulation, decision making is something that I want to touch a bit on because it's quite relevant to our discussions. And this is another way of looking at the policy process. The one that I would just want to highlight is the first one, which is agenda setting, deciding to decide. Very often, the greatest inertia is not even deciding to decide. So just hold everything off. Simply because when government does policies, it's a change process. And imagine when you're trying to change a community's view on something, you're trying to influence behaviors of people, organizations. It's a big challenge. It's not something that you can do. Not everyone can do it well. And there are great problems in terms of doing that. So then government needs to limit its agenda. When I was in the government as Secretary for Health, Welfare and Food, at that time we had a lot of problems because it was the first politically appointed government in Hong Kong. We were new, the whole system was embryonic. And then people said that you're changing too many things. We can't cope, the community can't cope with all these great visions of this new government and all the changes. It's impossible. So then the Chief Secretary, who coordinates all the policy secretaries, said, we can only do 10 things or 15 things in the whole of government for the next year. So too bad, boys, you all have to bid to put your major policies on the agenda. So we were limited to no more than 1 or 2 to be considered. So then you had all these people saying, oh, I've got all these things to do because my policy area has got so many problems, I need to do something. So you can, when the agenda setting is a lot of determined by a lot of things that we don't understand within government, they are not explicit, they are not made public, they're very internal. A lot of things are formal, a lot of things are not formal. So that's quite important part, deciding to decide of government and how to influence that. Decision making, I just want to highlight three choices: negative, positive, and non-decision. Negative is they make decisions, they do make the decision, but they don't want to change the status. So we say that we want to have anti-smoking laws. The government looked at it. Politically, we can't do it. Go. So when we were in government, we had all the preparation for the smoking, no banning indoor smoking, but because the political environment was not right, so my chief executive said to me, okay, oh, you've got all these things ready, but perhaps you should wait a year or two until the economic climate is somewhat better. Not that he would believe that would affect the economic structure, but there would be a perception that it might. And perception is reality in politics. So we held off that for a while. Positive, to change the status quo, which is what we all understand. And non-decision is not deciding, but its non-decision is that in many systems and many cultures, some of the minority groups are ignored, and because they are powerless, so their issues never even come up to the agenda. So they are purposely kept under the cloaks, so that that discussion doesn't even come into the policy discussions. So they're not even deciding to decide; they just ignore. It doesn't exist. So that's the issue. Some of the issues in policy science which are important. Briefly, I want to talk about some of these, and I want to highlight the garbage can model. I mean, there are many models of decision making. Rational model, I think, is what we understand. It's rational in terms of goal seeking, and then to look at all the consequences, and then the strategy to solve the problems. I think this is what we all identify with in sciences. But even here, with the rational model, the rational model incorporates not just biomedical sciences and public health sciences. It incorporates some of the policy sciences, incorporates behavioral sciences, which, because when you look at how organizations behave, it has a great influence on decision making. So there's a science decision making, and even in the rational model, there are different sciences that we need to consider. Incremental model means that very often you see that decisions are not made in one big bang. You have just increments. And mixed scanning is just they do a bit of scanning because of the imperfect evidence that's available. So they just choose a few, they scan it. These are the important ones, and then they do a bit more work with it. I think the garbage can model is a very, very nice description. I sort of identify with it because I see it happening in many places. It's quite interesting because the garbage can is where various problems and solutions are dumped. It's not really dumped because there are in that garbage can there are different things that come up, different problems. So NIHA may be proposing to change the world by doing certain things. The certain lobbyist groups, our competitors in different networks will say this is how we should be doing it. So champions for different advocate groups will put solutions, and there are problems which will people raise. The problems are from the community. Why aren't you dealing with our environmental problems? And then the media will then capture this in terms of framing the problem differently. So it's really the whole, all these things that happen in society, and then the labels or the shaping that thinking is how the problem is presented. As you know, that how a problem is presented will shape your thinking about the possible solutions. So then it's looking at all these. It depends on what garbage is being produced at that moment. So whatever is in there, and what goes in and what goes out, because sometimes things are forgotten. So you're not persistent enough, you leave the garbage can. It's not in the public's attention or not in the policy's attention. So it's not very fair to politicians to put this garbage can. But it does have some elements of the things that are happening in the policy arena that we need to understand, because it captures quite appropriately some of the things that happens in that different universe of policy making. I just want to end up by two things. One is to talk about evidence-informed policy and practice, or evidence-based practice, which is what we hope will happen. And here, this is a paper quite recent on talk about not evidence-based but evidence-informed. They talk about 3 stages of this evidence-based policy: the sourcing, the evidence in policy making, and the capacity for implementation. So we need to view it in terms of how you feed into the policy making process, how you influence the use of evidence in policy making, what influences the factors there, and then the capacity for implementation is a key part to that as well. And the factors in decision making, they found that the usefulness to the policymaker is a very important influence. The influence of the individual in terms of that person's understanding, that person's values, that person's benefits. So a lot of behavioral sciences are here as well, because it talks about not just the hard sciences, but also the influences on behavior, on the individual, and then we had discussions about the community, which is the organization. So organizational behavior has a great influence in terms of what those individuals do or don't do, because some of the policies will influence the thinking. So when you're in government's role is that is non-intervention in the markets. So whenever something comes out to the people that are formulating policy, and the solution is interventionist, they'll just automatically ignore it, or it just shut up from their considerations. So they just reject it even before looking at the whole context. So that has a big influence on the feeding into the organization. Of course, in the organization, there are different individuals. You can target certain individuals they know are more sympathetic, different levels of government. So it provides that capacity for us to look in terms of, if we want to influence decision making and bring in the science, what side of science is required, and then how do we target it. This is quite a lengthy list of things, but it's useful because it talks about the types of evidence. So we are up there in terms of the research, and there the types of research we do to provide evidence in terms of input. But there's the other parts of the knowledge would be the knowledge and information. And that, of course, in policy science, we consider it as evidence, because evidence is information, whether you consider it right or wrong, is information that people believe in that will affect their capacity to solve problems. So for them, it's evidence. And for the politicians, it's evidence. It's the knowledge and information. And this is result maybe in the consultation process, because governments are very fond when they do a policy to consult the public, and that provides the feedback in terms of what can and cannot be done. So that's also one element of the evidence. And there's a science to that in terms of how you collect the views, your questionnaire surveys, focus groups, and even in focus groups, there's a rigor in terms of how you collect the themes of discussion in the focus groups, the feedback in terms of Delphi techniques, because a lot of these qualitative things, although the science is not exact, but there's a science to it. And that captures some of the input, some of the evidence that you require for policy. So it's the type of research I'm saying, which is the research for policy. And then interest and ideas of individuals, politics and economics, I think. So these are all the different types of sciences and evidence that are required. Of course, we understand more about economics and the research because of cost effectiveness, etc., and the feasibility of all these things. I just want to end up by talking about two things. One is the application of that initial framework and the usefulness of this in looking at analysis of policy so that it provides the feedback in terms of how governments can learn from experiences and put it in a contextual way. So this was a study by in the World Bank study on corporatization of public hospitals, and they look at the implementation of the organization reforms to hospitals in the public sector. And of course, one of the hospital groups that were considered were Singapore, Malaysia, and Hong Kong. And they studied all the corporatization changes and used their policy triangle to evaluate the implementation of corporatization, because it provides then that framework, the context, where you can then compare, look at common things, and make deductions about what are things you need to consider and how things work and why things don't work. They look at the context, which is the historical, political, institutional factors. They look at the actors, so the people, the stakeholders, you can call them, but in policy science, they talk about actors. The politicians, bureaucrats, managers, health professionals, public impatients, public sector health workers, stakeholders. And they found that in the reforms, if you engage the important actors, they were more likely to be successful. I think the examples were in Singapore, when you move your corporatization, you did it in stages. In Hong Kong, we had a great consultation exercise. We had 35 very powerful staff unions that you had to negotiate and brought them in. I was a member of the union. I was brought in to be the chief executive of the hospital system. So they converted me to manage the system. So the actors are quite important in terms of the ability of the reforms to proceed and implemented as intended. And the process, they look at as I said, the first governance systems and the relationships and the approach to take into reform was also quite important in the implementation, as Singapore moved very carefully and very gingerly to incremental, so one pilot at a time. It provides the option to learn from experiences. Big bang is associated with high risk because you're changing too many things in the system at one time. So this framework provides the opportunity to learn, and then for countries to consider their own context, which is the appropriate model, because the context is different, the capacity is different for implementation. And in the content, they look at some of the consistency and coherence of the changes, because when you look at the incentive regimes, we talk about incentives, are they internally consistent? And then the arrangements for manual implementation. I just want to highlight that approach, that you can use some of these frameworks to look at the contextual factors and to study what the critical success factors. This is another framework which is really one of what we want to like here in terms of thought leaders. It doesn't add a lot to the discussions, but it provides a framework of the dynamism. They talk about the ecology of policy making. We heard about ecology earlier from Mark. It's the social climate and then the various parties involved, and it's dynamic, it's moving, it's ecological. So I think it highlights that concept, and that's why I put it forward. Finally, I just want to talk about, as what we discussed, we can look at our research in terms of policy, for policy, and the third one, which I've added, is to policy. Okay, so of policy is really usually retrospective, but it can be prospective, because you really study what has happened, and then you can evaluate it and it feedback in terms of understanding the process, the influences, how policy works or doesn't work, what are the success factors. But then research for policies tends to be more prospective. You're trying to help policy as you go along. So in the process of policy formulation, the consultative process, if you have a more structured way of looking at the inputs, then it provides that knowledge to policymakers in terms of what can and cannot be done for policy. So you're moving the process as you go along. So you're helping policymakers move along this trajectory of effective implementation. So it goes on from the stage of, after the stage of, maybe even from the stage of policy agenda setting. You can look at various stages, because your target people will be different and your approaches will be different. So the policy cycle helps us look at, even when we do work for policy, which are the areas we want to target and where do we target. So I find this quite useful in terms of then a more focused action in terms of for us today or in the future, about if we want to engage in policy research, where is it that we want to be engaged. And the final one is just to policy, where we're just very passive, but we then still need to recognize the whole process of policy is going to be a very important element in our objectives of improving health in Asia. So if we constantly not do it today, we must need to maybe partner with people that will then do some of that work, or we might consider some of those issues at a later stage. And my final slide is talking about challenges in designing research mental health policy. Obviously, it's quite important because the challenges are the qualitative and quantitative studies. Usually now people talk about intelligence designs. I mean, there's another buzzword, but it's really how you design, how you adapt. Because in the policy universe, the control experiments are more difficult. And criticisms about our control environment is that it provides internal validity, but it's not timely. Because as we talk about the dynamic nature of policy, you cannot do a control experiment at each stage of the way. So you have got to make do with whatever you're comfortable in terms of sensitivity of your methods. And also the criticism is also the external validity of our studies, the applicability to the people that use it. So there are questions if the researchers are not involved in the users not involved in the research, then there may be very little external validity in the designs, because you're designing in experimental conditions without regard to the real world. So people question the external validity of the research that we do. So that's something that we need to recognize. If we don't consider the policy perspective, there'll be a question of external validity. The data information sources is very challenging in policy, because very often it's from the external. It's academics who have not spent a single day in policy that are doing policy studies. So they look at it from a very academic and theoretical perspective without a real recognition of the real world. But obviously, as they go along, the inputs, the interactions with policymakers will provide them with a deeper understanding perspective, and then they change their models and change their approaches. But data sources are very important, because data and information sources, what are the reliable data and information sources? It's not as if in our scientific world, it's very well defined. So people have looking in terms of the information sources, usually be reliable sources, but how do you define reliable? Obviously, the one way to do it is to interview policymakers, but will they tell you the truth and nothing else but the truth? Obviously, because of the political nature of work, some things they are not at liberty to talk about the internal workings of government. So the data information are quite important. Sometimes we use secondary data. They use multiple sources of data, and they use the different approaches to provide the credibility and the confidence that that information data source is reliable. So there are a lot of approaches in policy work, and there are different designs. People talk intelligent designs. So even in terms of experimental research designs. So all these things that are relevant in our discussions, and then perhaps today or sometime in the future, you might want to consider them. Thank you.
Thanks, CK. Perhaps we could take 2 or 3 questions.
Thank you, Chairman. Professor, thank you for your talk. I have an observation and a question for you. Society sometimes become unwitting victims of information asymmetry, and that creates pockets of the noisy minority. And sometimes media comes into play and blows things out of proportion. The question I have is, how much weight should public policymaker put on public opinion that might shape public policy, in particular health policy? Thank you.
I think that's very interesting, because it's a dynamic process. It's not an either or. It's both influence. It depends on the system, the political system. Because if the political system is very powerful, very often these background noises will not occur. So when I was teaching public policy to my students, I gave them two reports on healthcare reforms. One is the China healthcare reforms, and one the US healthcare reform. And I asked them, what's the very obvious difference between the two? The China healthcare reforms was, in a period of time, very consistent. They talk about the same things, and 6 months later, the same things. It's very orderly. It just continues. And the people that made comments was the ministry spokesman, or the government spokesman, or one or two academics, like Professor Yang, didn't make any comments. But those were the only things that were very clear. Then when you look at the reforms in America, you have the Congress, you have the Senate, you have the lobby groups, you have the President's office, and then you see all the changes, dynamics, all the interactions, and when you look at it sequentially, the reforms change. The public option, I think, was the most obvious one. So it changes. So that structure, that environment will permit sort of these things. And of course, the media is very free in America. They challenge, they influence. In fact, they are policymakers because they interpret things. So Obama's reforms was interpreted as taking the rights from individuals, taking away your civil liberties, because you can't choose. You've got to go for these reforms. I can't choose not to have insurance, because Obama said you have got the insurance, although he omitted the public the option. So that environment is quite different. So it provides that input, and in those societies, government cannot ignore that, because it's part of that process, and they will have to act. They cannot just ignore this public opinion. And public opinion is shaped by a lot of people, very important influences. But government can also then participate. And the American government, the president's office, is very, very effective in its own PR and communications strategies. And I think when you see the presidential elections, it's so powerful. It creates this image. It shapes your thinking. So in that sort of environment, the societal interplay reflects the culture in the political system. And then in that context, you cannot ignore it. You have to play along. The rules of the game are different. So the rules of the game is going to be different in different political systems and different times of your politics.
Kai Hong first.
Okay, thanks for a very comprehensive literature review of this area. It's so gratifying and reassuring for a practitioner, ex-practitioner like you, to finally come to terms with the limitations of the biomedical. We've been teaching, say, health policy or health administration in the medical school is undervalued, is underappreciated, and perhaps it is the area where public policy and public health can interact and overlap with the applications of the biomedical sciences. Your garbage can model really reflects the messiness of the real world, but in this scientific approach towards looking at evidence-based policy, I wonder how much of that is really reflects the real world, because a lot of our evidence is really policy-based evidence. Policymakers trying to come back to academics to justify certain types of action and so on. So where do you draw the line between policy-based evidence and evidence-based policy?
Yeah, I did talk about that, because I say the application of evidence in policy and the use, as Kai Hong was saying, one way that this evidence is being used is to justify the actions. So that when you talk about evidence in policy, it can be in terms of using the evidence to support what the objectives of the advocate groups are, but very often it's also just used to justify why governments do or don't do certain things. So there are many ways that you can do that. But obviously the important thing is, that's why I said you need to understand the policy process and need to understand the dangers of it if we just ignore it, at least to be aware of it. And then if you want to influence it, how do you influence it, and what do you want to influence? So I think it's quite important. And on the medical school side, obviously Professor John Wong isn't here today, and the president's left, but Kee Sing is here. Obviously, I think the whole training of doctors I think the medical schools are always reviewing it. The importance of humanity is so important. It's not just policy. It's about human behaviors, organization behaviors. What's even more important is our understanding of patients. It's not just understanding of the political process. As practitioners, we don't even understand our patients and how they view health and illness. I think Mark would be sort of the champion of that in terms of individual behaviors. So understanding the behaviors of the people, the society that we live in, is one of the very basic elements of practitioners in health and public policy.
Maybe one short comment or question for Ted.
Just two comments prompted by your interesting and well-developed talk. Well, number one, So I think you should get a special honorary degree from your university in political science 101. You did a very good job. 2, I think there's a danger, and this is, as you know, I'm very well disposed towards your thing, but I think there's a danger in the presentation you gave that arises from your wish to be highly complex. You said you were worried about being simple-minded. You were the opposite of simple-minded. You were elaborate, and you elaborated almost every possible element you could think about. And there's a danger of that, particularly when you're thinking about teaching people about the politics of public policy. It's unwieldy. There's too many models. There's too many considerations. And I want to link that to, as a last point, to a thought that occurred to me in your category of research about public policy and Mark's earlier discussion of smoking cessation. And here's the link I offer for whatever it's worth in our deliberations. Mark said nothing in the smoking cessation area about the use of taxes to influence behavior in smoking. That was outside his zone. Nor did the word, for example, of the creation of a pariah of a smoker as an element in policy making here. And yet those are two quite powerful, if you think about that over the last 40 years, turning smoking from a chic activity to one which actually isolates people and treats them as they go out, for example, in University of Michigan when it's cold. Now, an example of your kind of research is the work that went on done by a group of scholars on smoking regulation in 8 countries all over the world, which actually tries to explain why there was a different timing of and a different policy tool used in 8 countries with the same scientific evidence done. That would be, it seems to me, okay, an example of learning about policy making that would cover a diversity of institutional settings. They don't give you an answer, but they would certainly sensitize you to those elements which help to explain why countries vary in their response to common scientific, and that's what's stimulated by your policy about it.
Thank you very much, Ted. I completely concur with you. It's one of my weaknesses to try to be too complex and comprehensive in my presentations. I accept that criticism. It's a weakness that I've not been able to overcome. But
it's a weakness that I've mentioned with affection.
but it's true. But it's really that's why I try to structure my talk slightly differently and raise certain issues. But I do recognize because a lot of things are quite new to different people in this audience because they come from very different backgrounds. And examples, I say, are a very powerful effect in terms of putting it in the context of the understanding. So thank you very much. I accept that.
We're running a bit late, but what I suggest is that instead of going on to the next 2 talks, maybe we should take a break. Maybe we should have an early tea break, and then after that we come back again.
But before we break, I just can't resist a quote from Einstein who said that explanations should be as simple as possible, but no simpler.
Dr. Jugman will speak on the role of regional networks in healthcare policy research.
So good morning. Thank you very much for the organizers for giving me this opportunity to share a few thoughts about that. I am relatively comfortable not following strictly the previous speakers in communicating experience, research, and being academics. Relatively comfortable to be a bit more advocating, because the organizer Sitaram knows me very well, so it took the risk. So too bad, Sitaram, you will have what you have asked for. So thank you very much for this opportunity. And again, it will not be evidence-based presentation, it will be experience-based presentation. So I am asked to talk about the network. So the first point is that I think in the case of NIHA in particular, we must bridge research and policy. The second point will be to talk about the regional network. Then I will give you the example of the Asian Pacific Health Observatory, which has started also. I will explain how I see the links with NIHA, and I will conclude. Bridging research and policy. I think when we are talking about health system, this is a priority. I know that some of you may think that research as such is important, but at the end of the day, you do research to have an influence. You want your research to be applied, to serve to something. So I think when you are starting to discuss about projects, about proposals, about research topic, etc., you must think about what kind of impact it may have. Here in this region, we need the research in health system and in the reforms. When people are talking about health sector reforms, at the end of the day, you are a bit tired because we have been talking about reforms for so many years. So we are wondering if we are going to continue to reform the health system forever. My answer is yes. My answer is yes, because the conditions are changing, and this region is particularly affected by these changing conditions. We have a different burden of diseases. You have the people moving from rural area to urban areas. We have people getting better off and demanding more higher quality services, demanding their access to medical devices which are more expensive and things like that. You have internet spreading around, mobile phone spreading around, so information for the patient is increasing. So you have to follow that, and you have to consider changing the system. So it's not a matter of keeping changing for the pleasure of reforming the system. It's just because you have to adapt to new demands. We keep changing. My second point is that regional cooperation and integration is important. We are in a global world. We are in a region which is just, the people are just moving around. They don't stay anymore where they are. You have the migrants, economic migrants, but you have also the tourists. You have everybody moving around in this region. The priorities of many countries in the region is to develop physical infrastructure. And with ADB, I know that because this is a priority for ADB, to develop the roads, etc. It has implication on the health system and on the demand of the people and on the risk for the diseases, etc. So regional cooperation and integration is something you must take into account. You cannot live in your own country, in your own borders, and forget that you are influenced by the neighbors, being economically, being through the migrants, being through the trade of goods, through the chicken which are crossing the borders, etc. So we must think that in this region that we are an integrated region. Neighboring countries are important, I mentioned that. The other point I wanted to mention is that you must think health, not necessarily health system. You must think that at the end of the day our objective is to improve health of the population in Asia. And perhaps, I do not say that NIHA should look at that, but keep in mind when you are talking about health that sometimes the other sectors have a much bigger impact on the health of the people than our health services. And this is particularly true. This is something which for me is extremely important working in Asian Development Bank, in ADB with many other sectors. We have a bigger impact on communicable diseases, for example, on watery, on diarrheas and things like that, if we work on providing good, safe water. That's a very easy example. The problem we face, is that those guys, sorry Sitaram, working on water supply and sanitation are convinced that they have an impact on health, but they do not follow up and they do not check how far it goes. So our job is, in the other sectors, to convince our colleagues that they must put health indicators to see if what they do has an impact on health. So we need the pipes and we need the sewages, etc., in the sector of water supply sanitation, but we need also to convince them to look at the health impact of what they do, not just how many pipes they have put, etc. It's the same for the roads. We have problems. If you build the roads, this is wonderful for economic development, but you increase also the risk of HIV/AIDS in communities which have never been reached by that road, which have been isolated for many years, for hundreds of years, etc. You must take that into consideration. So our job is also to preach health to other sectors. Now let me be a bit more academic, if I may, and forgive me if I say mistake, if I make mistakes. I'm trying my best, but this is not my field. So research actually generates knowledge. And if you have knowledge, on one hand, you have the generation of knowledge, accuracy, quality, sensitivity, lessons. This is something you know, you are the researcher, you know that better than me. Generating knowledge is not enough. This is the way I started the speech. I said that you have also to disseminate knowledge. If you keep your knowledge, it does not help. For dissemination of knowledge, you have quality, you have users, you have timely, you have feedback. This is something I think you should take into consideration when developing a research program related to the health system. You should think of the users. You should think of the feedback. You should think of the quality, sensitivity, lessons learned, etc. I am not going to come back on the comments of EK this morning, for example, on prospective, retrospective, and passive, etc. What I mean, why do I put this slide, is that because I think that for both knowledge generation and knowledge dissemination, you need partnership, you need network. You as researchers, you know that you have to be challenged by your peers to improve the quality of your research. This is for knowledge generation. I am adding that for knowledge dissemination, which is a huge problem, and I'm talking for me here, for me in Asian Development Bank, we have a wealth of research, of knowledge, if you want, but we are not able to disseminate it correctly. This is not your case, perhaps, but perhaps you should think about your target. So I am pleading that you also consider knowledge dissemination, and for that you need networks. And the networks are all networks. The networks with your peers, yes, but also relations with the other sectors, as I mentioned, also relations with the private sector, public-private sector, etc. Let me be a bit more. What are knowledge partnership networks? These are individuals, organizations who share a purpose or a goal. The members contribute knowledge, experience, resources, connections, two-way communication. Just think of a network that you have been involved recently, starting with NIHA. I hope NIHA will develop that network. Think about Health Observatory, Asia Pacific Health Observatory for those of you who have been involved in that. Think about the ASEAN ministers deciding the priorities in the region for ASEAN. All these are networks who have individuals, organizations sharing a goal, sharing knowledge, experience, resources, and connection, and two-way communications. Strategic, cultural, structural, and cultural fit. It is a collaborative process, and it is a joint decision-making process and action. These are the networks. These are the partnership. Difference between networks and organization. Some common attribute. These are a group of individual organizations sharing a goal who voluntarily contribute knowledge, experience, resource, connection towards a joint decision-making and action, and they rely on the partnership to reach that goal. Why networks are not organizations is because the knowledge partnership has a less formal structure than an organization. The participation is voluntary, as needed, not full-time. The participants have a high degree of freedom to make choices, and the nature of decision-making is distributive. I am becoming a bit academic there, sorry for that. At the end of the day, the organizations have managers, and the knowledge partnership networks have coordinators. Let me put in parentheses here why I am using the knowledge partnership rather than network as requested. It's because I believe that we all have something to learn from the others. I have a deep conviction that a partnership is always extremely useful, and you can always learn. So when you are talking about heterogeneous, very hugely diversified Asia, my conviction is that you can learn still. Hong Kong can learn from Cambodia and Laos. There are things that they are perhaps not exactly the same, but they are issues that you can raise. Oh, I did not think about that, etc. So really, I deeply believe in partnership among equals and sharing the information. So that's why I always put partnership and network. Relationship in knowledge partnership. What flows through knowledge partnership? You have knowledge, experience, resources, connections. On the other side, you have what makes knowledge partnership and network work. Here it's another, something new that I'm introducing. You have the trust which is needed. You have the reciprocity, you have the diversity, you have the complementarity. And here it's not because I am at this desk, but I would like to congratulate NUS because you have established as much as you could the necessary environment to have reciprocity, diversity, complementarity, and trust. So thank you for that. Trust is necessary. This is the glue that will hold networks together. Increasing information that flows between the nodes, character, honesty, integrity, principle, reciprocity, pre-existing, heritage, relationships. All that are things that you know. But to translate that, I think a very easy approach is just to think that you should be ready to listen to the people you are working with, and you can always learn something from them. You will not learn necessarily the solution from them because the conditions are different for you. But you can learn at least, perhaps, an issue that you have missed should be also considered in your health system or something like that. I am going to skip that because it's a boring slide with a lot of text. Okay, if you really want to know what it is, you just ask for a copy of my presentation and that's it. So let me now explain a bit about the Health Observatory, the Asia Pacific Health Observatory. I would like to mention that also yesterday, for example, we were discussing in our group about the ASEAN group of Minister of Health. This is also a network, and they must also be involved. I was discussing during the break with Kei Hong, and we were discussing that there are many networks in Asia. So I do not pretend that this is the only one. I'm just giving an example because it's something which is relatively recent, where ADB, the World Bank, and WHO, WEPRO, and CRO have been involved, and I just want to explain what it is. Again, the principle is that we have rapid changes in the region. How are these changes affecting health system? The problem is that we have limited evidence base to discuss about the reforms and what we have to change. What we have as evidence are usually evidences coming from the high-income countries. Then you may have conflicting advices. So, based on that observation, the three agencies for 2 years with participation of other development partners and some governments representative, etc., we have looked at what we could do. There have been studies made by the Alliance, etc. Though eventually we ended up by deciding that we would establish a Health Asia-Pacific Observatory to meet the policymakers' needs for high-quality, independent, comparative analysis and information on health system. We considered that as a regional public good. We want it to be at the regional level. These are our aspirations. I do not say that. Yes. Challenges. We don't have enough data. You know that. You are the researcher and you know that much better than me. We have, health system research is considered as a soft science. We have been discussing for the last, yesterday and this morning already, about the fact that it's extremely complex. We have political processes involved, etc. We have to balance the context and the comparability. We have a huge diversity in the region. and we have research networks which are not as well established as in Europe. Why do I mention Europe? Because for those of you who do not know that, the Asia-Pacific Health Observatory has been developed on the model of the European Observatory. What will the observatory do? On the model of the European Observatory, you will have country monitoring, HITS, health in transition. You will have cross-country analysis. But what is different in Asia is that we would like to emphasize communication of the evidence. This is an extremely important part of our job, to communicate with the policymakers and decision makers. And the last point, which is for me most important in the region, is building capacity for research in the region, strengthening the networks, helping develop the research hubs, etc. This is extremely important in our region. That's very different from what the Europeans are doing. NIHA, how does NIHA fit with all that? You have partnership. You want to address regional issues. You have technical expertise and resource. You have coordination. You have established coordination already and communication. You have an adaptive capacity. And here, let me make some advertisement. ADB is ready to support the regional partnership, even if I'm not there. That will continue. Conclusions. This is personal thought. I would like, when we do research in health system, etc., that we think beneficiaries. The beneficiaries are not the policymakers, are not those who have the money. Yes, you have to please them, but at the end of the day, think about the patients, about those who are suffering, who need your services. We have here a lot of experience and good practice in the region, and this is something we must share first among ourselves and with the others. Which is the reason, by the way, it may be useful to have a model similar to the European ones, because the Europeans must learn also from what we are doing in our region. So that's why I support perhaps a similar HIT and policy brief. They have to learn something from us. Knowledge management is collecting information, but also disseminate information. We need to build up the capacity here in the region to analyze the data that we have. Don't forget, as I mentioned at the beginning, that we have increasing connectivity and the goods and the people are moving around. So sharing information, disseminating information is a regional public good. Regional networks are a must. It's not a choice, it's a must. Next step, think about the other sectors. And at the end of the day, think that you can always have a win-win situation with your partners. So this closes my presentation. Thank you very much.
Thanks, Jack. Perhaps one or two questions, because Jack will have to run off to the airport soon.
Could I jump in? Jack, thank you very much for your presentation. I was once upon a time on the WHO WPRO Committee for Health Research, the regional committee. And we hear a lot of aspirations out of WHO over the years, and nothing sort of happens. And so what assurance is there that the observatory will be a new, innovative, progressive activity?
Thank you. This is a question I had also in ADB, and it's extremely important. Why will it be different? I think because both ADB and the World Bank and also the WHO, we do not want it to be a program for us. We want this program to be focused and to start with the research community. So this program is, ADB and the World Bank are there to help. The idea is that the WHO is there also for the legal aspects, to create an association and to have a reference, if you want, and help the Secretariat. But the core of the Asia-Pacific Observatory should be the research community. And that research community should complement NIHA, the ASEAN group of ministers, etc. It should not compete. It should be, we should establish that network. But really, I really sincerely hope that this Asia-Pacific Observatory will not be run neither by the WHO nor by the banks, but will be run by the research community, who will decide together what will be the program, etc. That's what I hope. That will be up to you guys to make it happen.
Yep, just one more comment. Yep.
Yes, I think one of the things you have to consider is that the idea that you want to base those networks on trust may be not a very good idea. I think we need a little bit more mistrust. If you want to have genuine information, what happens, say, about in China, you do not only want to listen to the minister or the principals of ministries, you also have to really have a mindset that's willing to challenge statements of formal policymakers or politicians or whoever's in ministry. I mean, when I worked in the ministry, I didn't believe my own minister. I knew he was talking politics, but that's something different from policy making. If you have a network and you want to continue to have an effective network, you do not only want to have a network that creates an epistemic community of people who like each other and have nice dinner parties together and have a good time together, but you also want to have critical people who are willing to disagree. You have to create an atmosphere of challenge and serious debate. Otherwise, it becomes a chummy group, and we've seen many examples of that in Europe. So I'm a bit wary of the ambition that you want to create a friendly society. I want to have a critical society.
No, if I may disagree with that, because here it's not a condition to have an effective network, but trust will help you to accept and consider the critics. In this part of the world, sorry for my friends here in Asia, but in this part of the world it's difficult to criticize up front. You can do that if you are friends. Then it's much easier to discuss and say, listen, friend, perhaps it's different. If you do not build trust, it will be very difficult for each other to criticize each other. And so I think that's the reason why I mentioned trust there. It's not because I refuse the critics. On the contrary, to make sure that you have a critic which is real and which will bring to changes, you need to be friend and accept the critics because the critic is coming from a friend, not because it's coming from government or from an NGO or whatever. That's the approach.
Okay, thank you, Jack. I think we should move on and have a good trip back.
Our final speaker for today's plenary session is Dr. Manjurani, scientist, WHO Western Pacific Regional Office. Her topic is Future Directions in Research for Health in the Western Pacific Region.
Good morning, and I would also start by thanking NIHA organizers to give WHO an opportunity to come and present what they are thinking and see how we can synergize with NIHA and contribute each other. I would just start my presentation by looking at where we are as far as concerned about research for health in our region. In Western Pacific region, we did analysis of all the scientific productions between 1992 to 2006, and what we realized that in Western Pacific region, actually we are one of the fastest growing region in terms of producing the research outputs in the area of health, with the total output increasing by almost 30% between 1992 and 2006. Even despite this increase, though, we still remain much behind Euro or America. I mean, our total share still remained at around 13.3%, which is much lower than our total population share, which is around 30% in the total global population. But what was more important finding, which was very, it was not surprising, I would say, it is one of the most concentrated research producing regions. So if we look at where did most of the research came or was produced from, it was mainly Japan and Australia, which accounted for 75% of the total research share. So most of the research for health which came from Western Pacific region, almost 50% came from Japan and another 25% came from Australia. And another issue we looked at, what is the major type of research that is being done in the region? And we looked at the major share was still the clinical and the biomedical research. followed by basic sciences research. The public health research or the health system research comprise much less share, especially in the developed countries. So if you look in Japan, even though it was the largest producer of the research in our region, only 1.5% was actually on the health system issues. However, when we look at the developing countries in the region, Vietnam or PNG, much greater share of the research, total research there was on the health system issue. It was mainly because most of the research there is donor initiated, as I'll speak in the next slide. So what we see here that we are making much more progress, we are producing a lot more research, but how it helping to change our health system still remains to be seen. Though, I mean, I must say that in the Western Pacific region, we did make a lot of progress, even in terms of the health indicators, but there's still this cluster of the country which are still lagging behind and still struggling with multiple healthcare issues. And I will try to focus mainly on the low and the middle income countries in our region. I think the healthcare issues are there in each and every country from multiple dimensions. But these are the countries where we are even struggling to bring their health outcome indicators even at par with the other countries in the region. And what we realize that in these countries we have almost no domestic funding for health research, even for the program evaluation or even the qualitative research day-to-day basis. So there's no funding which is assigned for this purpose. And if we analyze in these countries, most of the research is basically initiated, conducted and owned by external partners. We had several publications which came out on this. There's an analysis of the research done in Fiji, analysis of research done in Solomon Islands. So basically even who is deciding the research questions in these countries is all decided and initiated from outside. As a result, there's a poor ownership of the research with very limited involvement of the relevant stakeholder, either in designing the research or in using the research. Most of the time, what is undertaken in these countries has followed a very ad hoc approach. So if you look at their research portfolio, and one can clearly see some trends if you analyze their research portfolio over time, but those changes actually do not reflect what is happening in the country, but it more often reflects the trends in the global health agendas and advocacy. Professor, you did mention that international policies and agenda do affect the policies in the countries, and what we see, there's a lot of influence there. Unfortunately, it doesn't take into account the local health agenda and the local health problems currently the way the health research is being done in these countries. As a result, there is overall, when we talk to the policymaker, which I must say is not a homogeneous group, it's not one person or two person, there's multiple actors in different spheres. There is an inadequate awareness, there's an inadequate demand for the research, and also finally use of the research to inform the public health policies in the programs. So that was from the perspective of research agenda, who is doing the research and how it is going. But looking from the other angle, the way currently the whole industry of the research, global research is structured, is it anyway contributing to the building of capacity in the lower middle income country, so that over time they become more sustainable and start looking on their own research issues? And what we are seeing right now, again, when you look at the current status where the researchers are based, majority are in the high income countries, the funders are in high income countries, the site of research may be low and middle income countries, but the results are published again in high income countries, and who are using them, they are the future researchers from the high income countries. So there is this cycle that has been set up. So we had an increasing investment going on in the health research. We have increasing production of research. As I mentioned in my first slide, we have almost 30% growth, one of the fastest growing region, but it has not really actually contributing to the capacity building. There is a paper just came out in Lancet about young voices demand health research goal. And when you ask the researchers in the developing countries, they said we are basically used as the data collectors. So we have no role in defining. The research question comes defined from us, and we were just asked to contribute. So most of the time the data is collected and then it's shifted to the foreign institutions within country efforts just limited to the data collection or the descriptive work. And there's a reason for that. I mean, it's not a question of right or wrong or the policy. Sometimes because there are the deadlines, there are the grand deadlines, there's a deadline to produce the results and report, and everybody seems in a hurry that if they need to really analyze the data and publish the results, and there is an argument given that unless until we really bring out the results fast enough, we may lose the relevance. But in the whole process, then we don't have the time to really sit down with the people in the country where they are going to use it to analyze it in the way that leads to their long-term capacity building. And another outcome of that, the way the whole research is structured, a large share of data which is collecting for these countries remains unanalyzed, and nobody can actually access that. I was just having a meeting with the health minister in Kiribati, and we were discussing, because we were talking about introducing a new vaccine. I was talking, oh, you had just now had this survey, large nationwide survey done, and some of the data we can analyze from there. And he says, which survey? We don't have the data. It was taken away by them, and I don't know when the results are going to come. So many times the policymaker are not even aware of what is being collected, and it just goes, and which limits the effectiveness of the whole effort and the investments made there. So finally, coming to how do we change the whole picture. As I said, there are two aspects, there's two dimensions to the picture. One dimension is what are you being researching into? You want to provide more evidence. We are talking about the topics, where we do the research, this topic or that topic. But another issue is more from the management and the governance side, how the whole research enterprise is being governed and managed in the developing countries. Can we do something there to strengthen the capacity so that over time they become more involved, there's more ownership in the whole process? So if we look at many of these countries, there are basically no research management structures to track and manage the research which is conducted in these countries. So in that event, I think Professor Kesang yesterday said that we don't want to be a loose collection of multiple things here and there. We want a more holistic picture. To have that holistic picture, many of these developing countries, they need to have some overall research management and the governance structures. Most of the countries, they do not have any formal mechanism to review the research, either for its technical merits or for relevance to the local priorities, and even for the ethical issues. Right now in our region, not all the countries have even a single functioning ethical review committee to review what research is going on in those countries. And again, as I mentioned, unless until they put in some of their own funding as well, just to match the external funding, it will be very difficult to claim the ownership on that. And I'll just try to illustrate this point by another example. We just quickly, because there's a lot of issue on the migrant health policies in many countries, like in China, in Mongolia, even in Philippines. And these are the issues about the internal migrants coming from the rural to the urban areas. And the policymakers are really grappling with how do we provide services to these migrant population, which is reaching a very high, with substantial proportion of the total population. So I just quickly did a literature scan of what has been done in this direction, where are the gaps. And in China, for example, right from 95 to 2010, I could extract around 98 papers of the research. And there was a clear trend in what was being researched. And if you look at that, 41 out of 98 papers just dealt with HIV/AIDS. It was not because HIV/AIDS was the major issue in the migrant population. It was because there was a lot of international funding going into HIV/AIDS. And what that led to is a very imbalanced research portfolio in that country, and most of this research was very descriptive. It did help in the initial time to raise the advocacy, to bring visibility to the disease, but then the research community did not move forward in a very holistic way that, okay, this is next, we need to look into that. And there was very little, almost none intervention or evaluative research of different policy or the policy research. So it was a very imbalanced research portfolio, mainly driven in a very ad hoc manner by multiple partners. And the impact on the policymaker side was, first of all, they failed to get the answers they were looking for, but also from the research community side, by focusing on just one or two issues where the international priority was, they failed to bring the full public health impact or the economic implications of the healthcare issues affecting the migrants. They failed to present a more holistic picture of migrants to the policymaker, which could have led to much faster action than in this very ad hoc piecemeal approach. So now I just provided the statement of the problem where we are and how the whole research industry or the research endeavor is organized. Coming into the future directions, WHO has spelled out a global strategy for research in health, and it was approved by World Health Assembly in May 2010. It's available on the WHO website, anybody who wants to get access to. It defines 5 goals, and the first goal is organizational goal, capacity goal, priorities goal, standards and translation. I think the title of the goal itself sort of sheds light what it is all about, and I'll discuss briefly in connection to the Western Pacific region. So first is the capacity building goal. In that, we will try to at least have some more institutionalized measures in the countries to improve the overall governance of the health research. And first of all, that will be involving the priority setting, and I just use this word, backward translation of research. We always talk about the translation of the research, how the research has to be communicated to the policymakers to help them use that evidence to make the policy. But I think the first step is to have the policymaker convey their concern to the policymakers, to the researchers. So to ensure that the research, what the researchers are doing is more relevant by involving policymakers and program managers in defining the research questions. It should not be just based on the previous literature review. I have done my PhD, and when I was looking at what research I need to do and define my questions, that was basically based on what has the literature review done in the past and what are the different, so that should not be the way to go ahead looking at, because yes, research is incremental, science is incremental, but also, especially when we're talking about the system research or the operational research, we really need to involve the policymakers and program manager. I think there's no other area of the research, because in the biomedical research or in the basic sciences research, you do need those connections, but it's not that critical as in this area. And especially in the country, I was very amazed, like Professor Yo. There is this in some countries, this frequent exchange. You are suddenly in the policymaker, you are a practitioner, next day you are in a university. So you have that formal exchange which really facilitates this connection. But in many countries, that's not the case. The two groups are very different. There's never an exchange or never any connection. And that makes it all the more critical in those countries how we strengthen those linkages. In US, I was really impressed coming from India, where we have this really tight compartmentalization of the two and the mutual distrust. There's never an exchange. When I went to US, I was really impressed by that. Oh yeah, you can pick up people from university to lead the department. Then they can go back to the university, because it really broadens your perspective and horizon. But in many of the developing countries, that's not the case. You have that real missing link. So how do we institutionalize it? What role we have in sort of building that up? And then improving the quality of the research itself and the dissemination of the research result. And that involves, as I said, many of the countries in our region do not even have the basic ethical review, the technical review committees to review the research that is being submitted there. I did mention about what we can do to change the historical inequities in research for health, where we don't look at LMCs not just as places of data collection, but places where the results will be used. I think that's a very, as NIHA is structuring its partnership and all, I think that's a very relevant issue to look into. How do we structure more equitable collaborative partnerships that not only gives them the answers to some of the questions they are looking into, but also build their overall capacity in future that they can do some of the research on the ongoing basis by themselves. And there is all this question, I think we heard that presentation yesterday, how do we, in the area of biomedical research and other research, how do we develop incentives from the global perspective that encourage research and development in products that may help lower middle income countries? I think I already made this point that for any, whether it's WHO or for any other agencies which is trying to engage in research, especially in the health policy and system research, with a view to help some of these countries, we have to look into this broader issue of overall governance and management, and to ensure that we do build capacity in a very sustainable manner in those countries. I'll just give a brief, few minutes on what we are trying to do in that direction. As I said, if you look at the first goal in the global strategy is the organizational goal. So we have a lot of work to do within our own organization as well, and we are trying to take care of that too. And some of the examples we may set, we may be able to translate that into our member states. One of the major progress which has been made is this setting up of this international clinical trial registry platform, which really brings transparency. And I think this whole idea of making a clinical trial known even before the recruitment of the participant was very sort of revolutionary, I think, few years ago. But now I think there's a lot of movement towards to make the whole thing more transparent, and this international clinical trials registry platform has already been established, and China, Japan and Australia, they're all the primary registry and contributing data to that registry platform. We're trying to see if we can have similar system in the member state to track all the research done. So most of the efforts are basically, as I said, in this direction, building the capacity and ensuring the research is being translated. I can skip these slides because my colleague Jacques Jungman has already done my job. This is on the, I was trying to give a briefing on this, another initiative we are trying to do, the Asia Pacific Observatory on Health Systems and Policy. So I think I'll skip these slides, and if there are any question, I think most of them relate to what Jacques has said. So these are just the conclusions. Again, this is one of the most concentrated health research producing region, and how we make it more equitable, not just as a end in itself, but to improve the overall capacity and to ensure that we have more relevant research in the future. That's all from my side. Thank you so much.
Any questions or comments?
Thank you, Manju. That was a very nice presentation, and I think brought out some key issues. The question, the experience I have had in trying to do a large multi-center study for the ICMR, when we try to do research in the areas that they need, where it's needed most, we were having a lot of difficulty. So much of the research that you want to do in Asia Pacific region, those are dependent on the existence of a good healthcare infrastructure. And if you don't have a good healthcare infrastructure, you can't do much of what you want in those areas that are desperately needing it. So a lot of research is therefore skewed towards areas that have a good existing infrastructure, which may actually have completely different healthcare priorities and indices within countries. So that is one essential comment. The second comment I have is that we need to bring in a culture of research. Again, I talk about medical education at the level of undergraduation, which doesn't exist. Asking the right kind of research questions that are relevant to the needs of the population is not being done as of now. And only then can you change the way we think, doctors think about research, because there is a tremendous resistance from the medical community to get involved in research in this fashion that you're talking about.
Thank you. No, I fully agree with the comments made.
I usually try and make my comments very brief, but I just wanted to develop something here if I could, Manu. And thank you very much for a lovely overall picture. You didn't mention, and there's no criticism of WHO, it's helpful dialogue, I hope, the WHO STEPS program, which has been attempting to generate some good data on NCD and its risk factors in various countries with limited resources, which I think is an excellent initiative. I have some questions about the quality of data, but it's a good start. And sort of moving from that and the need for data and research activities, WHO does have a number of collaborating centres for NCD, diabetes, cardiovascular disease, but it's a sort of a relationship, which it's a nice relationship where we can meet together, but there's never any funding for those centres. And it seems to me that the opportunity, for example, with NIHA and WHO collaborating centres, that WHO and perhaps the ADB and World Bank should start to think about us moving things forward. We've sort of been sitting in space for 20 or 30 years talking about these issues, and taking collaborating centres like mine and our institute and NIHA and helping funding them to take responsibility for certain regions, to collect the data, to dialogue with those countries. I know exactly what you're talking about when researchers go into a major survey, take the data offshore, and the countries never get any feedback. So I'm just wondering whether we need to have a little, and this applies also to the observatory project, that I think instead of just having these relationships which are very passive, there needs to be much more active relationships, and WHO to start putting, instead of, I've just chaired the WHO Expert Committee on Diabetes. We met 1.5 years ago, and the report is paralysed within the WHO system, actually, because of evidence-based. There's an evidence-based committee, and this and that and the other. And I think we need a bit of action.
No, I think these are excellent comments, and I fully agree with you. And if you look at in our research strategy, the first goal is actually organizational goal, which is completely focused on WHO and overhauling its own systems. And I think I really liked your comment about the collaborating centers and NIHA and working more actively with them, and to sort of help them mobilize more resources, and not only collaborating center with and between WHO and collaborating center, but developing those sort of networks of collaborating center across member states. So I think definitely that's a very good suggestion, and I have taken note of it, and we'll definitely work on that.
Thank you, Chair. Manju, I have two observations with respect to doing research in low middle income countries. The first one has something to do with the perception that there's no money in research and the inequity of health professionals' pay. I mean, we have colleagues who are in the clinical field, seems to believe that doing clinical work will give them more pay rather than investing time in research. The second thing is something that the WHO perhaps can look into more carefully, in that in centers where there is an ethical review board, but the research is not very often, they're far in between, the ethical review process takes a very long time, that discourages a lot of good researchers from pursuing good research. Thank you.
Thank you so much, Ken, for making this comment. And again, that brings to the issue of the governance when you said the ERC. So how you streamline and how we take the efforts to forward in improving the overall governance of health research, where it helps to improve, but at the same time does not become an obstacle in pursuing the research. So these are some of the issues we are actually trying to look, and how we can make it sort of move into in a more systematic way in this direction when we work with these countries.
Small countries first, thank you. I have one very specific question about the intellectual ownership of the publications of the observatory, because that's an issue that hasn't really been solved very well with the European observatory, and I think it's an important one. in Europe they've now published about 50 booklets of country studies, and some are pretty good, some are pretty bad. And the problem is it's not quite clear who actually owns the content. There's no real peer review. There's a very heavy hand of the editing by the staff of the observatory, and some have, been the result. But so you don't know whether you are reading reports of an international organization, whether you're reading reports of governments. In some cases, government officials have written a report, like in Canada, for example, or whether you're reading a series of serious academic publications with a serious effort to understand the making of policy. Or are we reading government reports? Are we reading WHO? And I think it's an important issue, and maybe, I don't know how you have solved it here, but maybe it's good to think about that before you are commissioning out another 50 of those books.
No, again, I think this is an excellent issue. I have not yet been involved at this level of detail with the observatory, but I think I'll definitely make a note and convey this. This is definitely an issue we should consider before we come out with the products in observatory. Thank you so much.
Okay, just a couple of comments and suggestions. I think now WHO has developed a couple of strategies. For example, 5-year strategies in financing, 5-year strategy for essential drugs, and maybe there are some others. But my comments is that those kind of the strategies need to be combined with the local, or need to be combined with the country development strategies. Otherwise, the WHO strategy cannot be well implemented. The second way is that for implementing those strategies, WHO need to identify some key issues to conduct studies in the country. Saying that, I think the local the WHO country office will be playing very important role. So that my suggestion is that in the future the country office should be the capacity of the country office need to be strengthened, and all the country office need to well combined with the local institutes. That's my suggestions.
I think you can hear me. Highlight the need for building capacity in these countries. I can only speak from the context in India, but we have to manage the expectations. Right now, the government is increasingly asking for research, which is very encouraging, but the timelines they are using are extremely short. They want the results before the next election. And if you want to give that, then you basically have to bring in the best researchers in the world. So that needed capacity building of the local researchers, that takes probably 3-4 months to bring them up to speed. It's not time for it. And the World Bank is working in the same way. And that is not only the politicians, it's also the donors. So the 12-month period to do a research study, then you don't have time to build the critical capacity to do the research work.
Okay, thank you everyone for their comments, and let's thank the speakers for sharing with us. I'll go on to give you a piece of good news first. We're going to shorten the next breakout session so that we'll be able to come back by 12:45. Then we can have a short closing, and then we can have lunch, and many of you are leaving immediately after lunch. So the next breakout session will be until 12:45, right? Just for about an hour. Right. So the groupings will still be the same, right? The ushers will be just outside immediately to show you where to go to. There are 2 other ideas that I'd like to introduce through this breakout session. One is, we have discussed quite a bit today about the need to have a lot of contextual issues, how to synthesize evidence from various angles, not just biomedical, but a lot of political angle as well as a social angle to the evidence. One proposal that we have is perhaps NIHA can attempt to have a modeling and simulation capability to be able to synthesize the evidence together for policy making. So many times when we perform our research, and in order to translate it into a policy level, you need to quantify the impact of for example, the risk factors in the population. You need to predict the outcomes of programs. You need to predict the impact of a policy in a particular country. In an example of, say, for example, a chronic disease, say in the case of breast cancer, we now have all the genetic markers. How do you predict or how do you quantify the impact of these genetic markers in a particular population? If, for example, you do have a particular program using these genetic markers, what will be the reduction, for example, in mortality if women with higher genetic risks, for example, are screened more regularly? Of course, you can conduct a typical epidemiological study, but by the time you conducted the study, the findings are out of date, and it's quite useless in terms of implementing into policies. And if you do have a policy, what are the implications if you really stratify the whole population by genetic risk? It's not just a biomedical approach. Acceptance by the population, will you lose votes at the next election, and so forth. Similarly, in the area of, say, infectious disease, if the next H1N1 outbreak is just as contagious, but if it's 5 times more virulent, what is the impact on the healthcare setting? How will school closures, for example, alter the transmission? And again, you cannot conduct a study. You have to come up with simulation and modeling to see what kind of scenarios will happen to you. So the proposal that we have is that to build a modeling and simulation capability that is not just based on a single type of models, but interplay of different kind of mathematical models. Epidemiological modeling, econometric modeling, systems dynamics modeling, just to name a few, and doing micro simulations and so forth. But that capacity will not work if it does not sit on a data warehouse. We realize that a lot of times there's a paucity of data, but actually there is also quite a lot of data that is already existing, that's routinely collected both internationally as well as locally. And secondly, having that capacity also to go out to conduct surveys, go out to conduct qualitative studies. So we're suggesting that perhaps NIHA could have such kind of a capability, starting off perhaps on a small scale, on a specific project, either in chronic disease or incommunicable disease, and then slowly build that up. So as part of your breakout group discussion, we'd like to give you, perhaps you can go through this exercise, one example in chronic disease and one in incommunicable disease, in terms of quantifying the impact of risk factors, predicting outcomes of a program, or predicting the impact of a policy in your country. You can choose anything. If you can't think of a particular disease area, maybe type 2 diabetes or obesity or bird flu, and try to work through that, and then we could use that to share it and to see whether is such a modeling capability really useful for policy setting. And a second example or second key thought I want to introduce is, for lack of a better term, piloting kind of model communities. And this may also be part of the research grants call that subsequently NIHA could put up. That more than just collecting data, more than just collecting, say, prevalence of risk factors, is to have some kind of interventions, a pilot intervention study in a small scale, in a community, perhaps in a rural environment or in an urban environment or in a workplace environment. So take, for example, like integrating microfinancing with public health, going beyond water and sanitation to diet and chronic disease prevention in a rural community. Right? For workplace health kind of a situation, perhaps integrating workplace safety and health, going beyond the traditional occupational health, toxicology, to general diseases, prevention in the workplace, as well as productivity of aging workforce. So these are just some ideas that I'm throwing up. that perhaps the breakout groups could discuss. Firstly, the modeling and simulation capability. Secondly, potential of piloting some model communities in terms of some interventions in our various regions. Right. So let's go out to our respective groups now, and then perhaps come back, be in time by 12:45. Thank you.
Good afternoon, ladies and gentlemen, and welcome back to the final plenary session of the forum. I would like to introduce Dr. Jeremy Lim, Senior Consultant, Ministry of Health, Singapore, and I request Dr. Lim to please deliver the closing remarks for the forum.
Thank you very much. Before I begin, can I play a little video to let everyone know what was reported in the news yesterday? And I hope the sound works.
Pandemics such as H1N1 and SARS have shown just how vulnerable Asia is in dealing with infectious diseases transmitted from animals to humans. Health experts say the traditional way authorities combat these diseases is also problematic.
We're identifying the disease first in humans. Then we go back and find the animal in which it's occurring. What we'd like to see is the infection first identified in animals and prevented from coming to humans.
Professor Heyman says funding a collaborative approach with veterinary sectors is one way outbreaks can be prevented. Other health professionals also wanted the focus to be on non-communicable diseases such as diabetes. In Singapore, the rate of diabetes has risen to a 12-year high.
We want to see a much larger amount of money put in to the prevention of these diseases because they're having huge impact on economies of countries and in fact could bankrupt the economies of a number of Asian countries unless the non-communicable diseases are prevented. Funding so far mainly goes to infectious diseases in the rest of Asia.
These concerns will form part of an initiative by NUS to develop research to combat health issues in Asia. Leaders say strategic intervention will require working with governments and policymakers. Station Inspector Kelly Liao Kek Leng has been with the Singapore Police Force.
Okay. Sorry, that was not part of the... And don't worry, the police force is not waiting outside. So Jeremy and... Okay, never mind. Okay, ladies and gentlemen, thank you for being with us these last 1.5 days. It has been said that a conclusion is the place where you get tired of thinking. And for those of you who are eagerly waiting for intellectual stimulation, I'm afraid you're in the wrong place. All right, what I would like to do over the next couple of minutes is really to sum up what have been the key messages that have come from all of you in these last 1.5 days. And I realize I'm the only thing standing between you and lunch, so I will be very brief. All right. Since I wasn't too sure what would be the takeaway points and the mandate given to me by the organizing committee was to sum up, so I decided to start with President George Bush and also Sarah Palin, because you cannot go wrong with George Bush and Sarah Palin. And I decided to take 2 choice quotes, and thankfully they have both said very remarkable things about Asia, which really brings up the first point, which is around misinformation, fallacies, and outright lies. Right? And that's something that NIHA will have to strive very hard to overcome, to get the lingo right, to get the facts right. And permit me to share the immortal words of George W. Bush in the year 2002 when he visited Tokyo, where he said, "For a century and a half now, America and Japan have formed one of the great and enduring alliances of modern times." Someone forgot to tell him about the Second World War, but that's all right, because Sarah Palin, potential US president in the year 2012, said last week, "We've got to stand with our North Korean allies." So, first order of the day that we hear from all of you is to get the facts out and get them right. Right? The second message that we have gotten is that really a key message is to develop the toolkit. And this toolkit is a very precise one. We need to be able to articulate what are the tools, what are they to be used for, under what situations, under what circumstances will these tools be useful, when would other tools that are not in this toolkit be even more relevant, be even more applicable. And NIHA cannot be all things to all men. Over the next day and culminating in the IAB meeting tomorrow morning, NIHA will have to focus, will have to very, very sharply crystallize what NIHA is about, and just as importantly, what it is not. And these tools can then be developed jointly with all of you and developed so that they are of use to end users, policymakers, and also academics. See, notice the deliberate absence of any words, because I wasn't quite sure what I was supposed to say until about 3 minutes ago. So these are ubiquitous, can be used in any form. Okay, the third message that we have gotten was that we need to think very, very broadly, beyond geography, beyond sectors, and something that the French novelist Marcel Proust had spoken about previously, where he said that the real voyage consists not in seeking new landscapes, but in having new eyes. And that's something that when we talked about new ideas, we hope that NIHA will be a very appropriate forum to learn new things, to see the world with new eyes. And finally, the way we started the forum yesterday morning, when Minister Kaur spoke about the importance of networks and making friends. And I would say to all of you that good friends are like stars. You don't always see them, but you know they're always there. Right? And that's what we would like NIHA to be, a very powerful platform for you to know who each other are, opportunities to work together. And on this note, I would like to highlight that all of you have this little flyer, which is around the NIHA Leadership Program, and I would encourage you all to bombard Ted and also Jeremy with lots of questions about who is appropriate, who should attend, what are some of the things that you would like to put into the program. All right. The second announcement I would like to make is that I'm very pleased that NUS has offered NIHA as a platform for academics, for policymakers from government to spend a limited period of time, couple of weeks, a couple of months, to step back, to sit down and think in a short-term sabbatical fellowship. And this is another opportunity to grow the network and perhaps take some time off our very busy schedules to reflect and perhaps to then grow the body of knowledge that would benefit all of us. And I do realize, as I said, that I'm the only thing standing between you and lunch. So I will take Professor Chia Ki-seng's good advice that closing remarks should be like a skirt, the shorter the better, covering only the essential points. And so the take-home I would offer to all of you is from this commentary that Professor Sitaram and I had written, and the words in blue: despite the vastly different socio-economic conditions between Asian countries, we all want the same things: affordable and quality healthcare available to all citizens. And if this is our endpoint, the ultimate goal we are all striving for, we hope that NIHA will be part of this very valuable journey towards achieving affordable and quality healthcare available to all citizens. And on this note, on behalf of the organizers, I'd like to thank all of you for a very fruitful conference. I would love to be able to say let's adjourn for lunch, but I understand that there are some housekeeping announcements, and so I will take my leave. Thank you very much.
Thank you, Dr. Lim. I'm sorry for delaying your lunch break, but just two quick announcements. Those of you who are staying at the Traders Hotel, there is a bus that will be available for you to take you back to the hotel at 2:30 p.m. at the lobby. Also, those of you who will be with us in Singapore tonight, we would like to invite you to join us for an informal dinner at the Straits Kitchen, which is at the Grand Hyatt, where we went yesterday as well. A bus will be waiting at the Traders Hotel at 7 o'clock to bring you to the dinner venue, and will take you back at 9:15. Thank you. We can now move down for lunch at Nexus Level 6.